share.
Doctor, we are live now.
Yeah, is it?
Just a minute, I can't see. How do I desktop? No. How do I share?
There must be an option of sharing at the bottom, sir.
Yes, share I have clicked. Then apply Zoom Workplace to share your screen.
Yes.
Open system settings.
You'll have to go to open system settings and allow the screen sharing.
Okay, and then open system. Then what do I do?
Manjula, sir, is it a Mac or it's a laptop?
Mac.
Mac.
Zoom.
Doctor, keep your file open in the desktop, doctor. Then you share screen. Do the share screen.
Okay. So first of all, I open my Zoom would like to record this.
Yeah. Yes. Yes.
In the bottom, there is a share button, doctor.
It says
I think I'll just connect with him once.
Okay, doctor.
Nitesh, in the meanwhile, you can just ask. बॉस शायद दोबारा लॉगिन करना पड़ेगा आपको.
बस फिर से लॉगिन करना पड़ेगा.
okay. So now I'm back. Now if I share the screen,
Yes, sir. Try and share the screen, sir. Yeah. So we can see it now. Yes, it is visible.
Yes.
Yeah.
Okay, I'll go to the slideshow.
Sir, just we'll start it and we'll formally announce this session open. So
my slide and my audio is
yes, yes, sir. Everything is okay, sir.
Okay.
So good evening, everyone. So as you all know that Rajasthan Ophthalmological Society runs a PG teaching webinar in the name of Kaksha series. So today we are back with the 34th edition of the Kaksha series, which is on target IOP and medical management of glaucoma. And we have Dr. Sanjay Kumar Daulat Thakur with us, who is an expert in glaucoma, and he'll be taking your masterclass. And Dr. Nitesh Bansal will be the moderator for this session, and we'll have Dr. Madhuri and Dr. Mitali on the hot seat. So in the end of this session, we will have 2 questions, and those questions will fetch prizes. The first one to type the answer in the chat box will get the prizes. So over to you, Nitesh. I'll request you to please introduce Dr. Sanjay sir for this webinar and the masterclass. Over to you, Nitesh.
Thank you, Dr. Ankur Sinha, sir. Am I audible?
Yes, yes, absolutely.
So first of all, I just wanted to brief about Kaksha. Kaksha is a novel online teaching program for PGs, which actually covers all major and important topics, including correct curriculum of postgraduates. In this, we invite national and state faculties who interacts with postgraduates and also with the ophthalmology practitioners. Here we encourage residents to put forward their doubts and interact freely with the faculties. So coming to the today's class, we have one more eminent faculty, Dr. Sanjay.
ஹெட்டிங் கொடுத்துருக்காங்களோ அதை எழுதணும். அப்ப டிராயிங் மட்டும் அது வரையலாமா? டிராயிங் மட்டும் இது அக்காதா? ஓ ஓகே ஓகே ஓகே.
Somebody else is speaking. I am not speaking.
இது
Someone is there actually.
Manjula, I think you have to switch off your mic. Thank you, Manjula. Yeah.
So today we are having one more eminent faculty, Dr. Sanjay Kumar Thakur, who is HOD ophthalmology in the College of Medicine, Sagor Datta Hospital. I just want to introduce him. I have a long list of having about him. He is a award winner of various awards, Achievement Award in All India Ophthalmological Society, Jaipur 2026. He also won Guru Sangram Award, International Ophthalmic Hero of the India, Best Paper of the Session, Colonel Rangachari Award contestant. Oh my God, I am having a long list, so it would be difficult for me to introduce the whole. And he is a general reviewer of clinical and experimental ophthalmology, Nepalese Journal of Ophthalmology, Indian Journal of Ophthalmology, BMC of Ophthalmology. He is having academic and expert roles in international expert, National Institute of Health Research, NHS UK. He has been invited variously more than 160 times international, national at the state conferences, assessor for NMC and National Board of Examination. So sir, I welcome you on behalf of ROS, and we are very delighted to have you here. Definitely we all and all the residents will get benefit from your knowledge. So sir, please start your question.
Thank you for the kind introduction, Dr. Nitesh, and thank you, Dr. Ankur, for giving me this opportunity. I am very grateful to you, both of you. And with this, I start my talk. My topic is target IOP and medical management of glaucoma. So, whenever we have a patient of glaucoma, we have to remember what are the goals of the treatment. We don't have to control the IOP in the target range. Not only we have to control the IOP in the target range, but we also have to keep the optic nerve status and visual field stable. Both the optic nerve status and the visual fields should be stable throughout the treatment. So we have to control the IOP in the target range. We have to keep the optic nerve and the visual fields stable. Now, what is target IOP? The aim is to lower the IOP to slow the visual field deterioration to a rate sufficient to maintain the patient's quality of life. And the target IOP is the upper limit of the IOP just to be compatible with this goal. No single target IOP is fixed for all the patients. It has to be individualized and it has to be re-evaluated regularly. So it's not that we do it once and we forget it for the whole lifetime, or there is no single target IOP for all the glaucoma patients. So what are the factors which help us in determining the target IOP? If the glaucoma damage is advanced, then we have to keep the target IOP lower, in the lower range. If the life expectancy is short, then we can keep a higher target IOP. If the rate of progression is fast, then we have to keep a lower target IOP. We also have to remember that central corneal thickness is an independent risk factor for glaucoma. And if the patient is one-eyed, or if the family, if there's a family history of glaucoma, then also we have to keep the IOP in the lower target range. So all these factors need to be considered before we decide what should be the target pressure for that individual. Now, as I said, the first one, the glaucoma damage. How much is the glaucoma damage? That will determine the target IOP. So how do we classify the damage of glaucoma or glaucoma damage? We can classify it into early glaucoma, moderate glaucoma, and advanced glaucoma. And we can do this classification based on the disc and the visual fields. If the VCDR vertical cup disc ratio is 0.6 to 0.7, then it is moderate glaucoma. Anything above 0.8 is advanced glaucoma. Similarly, if the visual field damage, the mean deviation is less than 6 decibels, then it is early glaucoma. If it is more than 12 decibels, the mean deviation is more than 12 decibels, then it is advanced glaucoma. So, without going into a complicated rules, I will give you a simple empirical formula to determine the target intraocular pressure. We have to reduce 20% in case of early glaucoma, 30% in moderate glaucoma, and 40% for advanced glaucoma. Another way to remember the target intraocular pressure would be that we can keep the target intraocular pressure in high teens in early glaucoma, but we have to keep it in low teens in advanced glaucoma. Now, whenever we have a patient of glaucoma who we have diagnosed after considering all the factors, then we have to start with a monotherapy. And when we start the monotherapy, we have to keep the patient characteristics like systemic profile, his quality of life, his characteristics, whether he'll comply with the drug regime or not. Similarly, we also have to keep the drug properties in mind. What is the IOP? It will cause a reduction of IOP. How much IOP it will reduce? What that is determined by the drug, whether it is preservative free or not, because nowadays we are more concerned about the ocular surface because it's a lifelong treatment. So whether it is preservative free or it is having preservatives, and the cost, which is also very important because the patient has to continue the drops for the lifelong, his whole life. So cost is an important factor. So what are the drugs available to us for treating glaucoma? When I started my house job in ophthalmology way back in 1991, we had only two drugs, pilocarpine and timolol. But thankfully, now we have a wide range of drugs like prostaglandin analogs, carbonic anhydrase inhibitors, and the latest one is the Rho kinase inhibitors. We must know the mechanism of action. This is basically theory. We all know that prostaglandin analogs increase the evioscleral pathway, outflow of the aqueous through the evioscleral pathway. Beta blockers decrease IOP production by acting on the ciliary body epithelium. Carbonic anhydrase inhibitors, as the name suggests, they inhibit the carbonic anhydrase enzyme and decrease the aqueous production, and so on. So today I will be focusing on the practical aspect of the management of the patients with glaucoma. So when we are starting the first drug, we should start with the drug that has the greatest chance of reaching the target IOP. It has a good safety and tolerability profiles, and it should be affordable. And one more important thing is we should not forget to teach the technique of eye drop instillation to every patient of glaucoma. In our busy schedule, we forget this. We assume that the patient knows how to put the eye drops. But even if the patient knows it, we should reinforce it, how to put an eye drop. And especially, we should also reinforce the punctal occlusion technique. Some surgeons start with one-eyed therapeutic trial, but nowadays most of us don't go for one-eyed therapeutic trial. Now the treatment is considered to be effective when the IOP reduction is compared to the published range. Suppose that we are starting with timolol, which is a beta blocker, so we expect about 20 to 25% reduction of IOP. If after starting the drug, we see that there's a reduction in the range of 20%, then the treatment is considered to be effective. But suppose it does not achieve a 20% reduction, it achieves less than 10% reduction. That means the drug is not effective in this patient. Then we have to switch to another monotherapy. And one of the important points, whenever we start the patient on glaucoma treatment, we have to educate the patient about the disease, about the glaucoma disease, that there is not going to be any immediate benefit as far as visual acuity is concerned, or any pain relief is concerned, or anything of that sort, or there is no relief as far as symptoms are concerned. So we are only trying to preserve the visual field. So we have to educate the patient, because the patient does not know this and he expects something more rewarding. And after some time, he becomes non-compliant because he does not see anything concrete as far as benefits are concerned. So patient education about the disease is very important. And patients are not very, what you say, uh, disciplined about the drug use. So we have to use some reminder systems like cell phone alarms to improve compliance. Otherwise, they may forget to put the drops. So initially, we can start with beta blockers or prostaglandin analogs. In government hospitals, beta blockers is one of the choices because it is less expensive, it is affordable. The only disadvantage is it has to be put twice daily, so the compliance decreases. Patient forgets to put the drop sometimes. The prostaglandin analogs have the advantage of once daily dosage, so the compliance is better, but it is costly. So these are the factors we have to keep in mind. And whenever we start the drug, we also have to remember that if the patient is having COPD or asthma or congestive heart failure, then we should avoid beta blockers. Similarly, if the patient is having herpetic keratitis or uveitis, then we should avoid prostaglandin analogs. So we have to remember the potential contraindications before starting the drug. And once we start the glaucoma medication, then we have to keep the adverse effects in mind. Whenever the patient comes to us for follow-up, we should have this in mind to see whether the patient is having adverse effects or not, because then the compliance will reduce. So in case of prostaglandin analogs, we can have hypertrichosis, periocular hyperpigmentation. In case of beta blockers, we can have bronchospasm, bradycardia, depression. In case of topical carbonic anhydrase inhibitors, we can have metallic taste. In case of rho kinase inhibitors, we can have hyperemia, cornea verticillata. So we should have these adverse effects in mind when the patient comes to us for follow-up after starting treatment. We have to switch the drug, as I said, if the patient is intolerant to the prescribed drug, or if the contraindications to the drug develop, or if the patient does not adhere to the prescribed medical regime. And we have to add second drug if the target IOP is not achieved, or even if the target IOP is achieved, there is a progressive damage to the optic nerve or the visual field damage. So in that case, we have to add a second drug. When we add a second drug, it should be from a different class to get the maximum benefit. And usually we prefer fixed drug combinations because of convenience of one bottle, lower cost, more importantly, decreased exposure to preservatives, and it also improves adherence. It avoids the potential washout of the first drug. So these factors help us to choose a fixed drug combination. Now, what are the fixed drug combinations available in the market? We have prostaglandin analogs and beta blockers, two of the most common drugs used. We also have carbonic anhydrase inhibitors with beta blockers. We also nowadays have a triple drug combinations like brinzolamide, brimonidine, and tremolol. So we have a wide choice now as far as fixed drug combinations are concerned. This is an algorithm developed by European Glaucoma Society for management of glaucoma patients. So if we start with a drug and it is well tolerated and we have the IOP in the target range, then we just follow it up periodically. But if the IOP is not decreased to a published range or expected range, then we switch the monotherapy. And if the second drug, if the monotherapy now is reducing the IOP in the published range, but the target IOP is not reached, then we add a second drug. Now, some surgeons in this situation prefers selective laser trabeculoplasty, SLT. And some people nowadays, some glaucoma specialists even use SLT as the first option. But European Glaucoma Society says we can use SLT as an adjunct to the first drug before adding another drug. So it is personal choice. You can add a second drug or you can do a SLT. Now, if the target IOP is achieved, then we periodically do a follow-up. But if the target IOP is not achieved even after adding the second drug, then we go in for the third drug and so on till we reach the maximal medical therapy. And if it's still the target IOP is not achieved, then we go in for surgery. As I said, SLT is now an option as an adjunct to the medical therapy. We used to do argon laser trabeculoplasty in the past, but nowadays SLT has become the preferred choice because it is relatively effective, non-invasive, and it avoids the problem of adherence and it is easy to perform. The only problem is it effect wears off after some years. Now, the next important thing is when the patient comes to us for follow-up, what should we check? We should check for the subjective well-being, visual function, quality of life. We should reassess the risk factors, especially IOP, different times of day, and we should also periodically do gonioscopy. It is not that we do gonioscopy at the beginning to classify glaucoma, whether it is open angle or angle closure, and then forget it for the lifetime. Remember, we have to do gonioscopy periodically at least once a year, even if it is a patient of a primary open angle glaucoma. We have to reassess the structure like visual fields and the function of the optic nerve. Then we have to estimate the rate of progression and see its significance in relation to patient's age. We have to identify the adverse effects of treatment, systemic and local. We have to assess adherence, whether the patient is adherent to the treatment plan or not. Sometimes the patient says, yes, I am following the drug regime, and in spite of that, the disc is progressing, the cup disc ratio is progressing, and the visual fields are progressing. Then, first of all, we should check the adherence before adding a second drug. Patient tries to hide this, thinking that it will be a bad image for him, but then you have to remember that if you add a second drug and if he still is not adhering, then again we will have this IOP fluctuations. And to avoid non-adherence or non-compliance or to achieve better compliance, we should always reinforce the patient information about glaucoma. Now, next important thing is how frequently we should do the follow-ups. If the target IOP is achieved and there is no progression of damage, and if the duration of control is more than 6 months, then we can do a follow-up annually. But if there is a progression of damage, either in the disc like VCDR or the visual fields, then we have to do a frequent follow-up 1 to 2 monthly. Adherence is a big issue, not only in India, globally. The non-compliance rates vary from 20 to 60% according to some studies. And it leads to IOP fluctuation and worsening of disease and unnecessary addition of the drugs. So how can we improve adherence? We have to improve the patient-physician relation. The patient should be confident in the physician, then only he will adhere to the drug regime. We have to enforce the patient's education of glaucoma so that he realizes the impact of glaucoma on the visual fields and also realizes that there is no improvement in the visual acuity. We should try to streamline the drug regime to the patient's lifestyle to some daily activity so that he remembers while doing that daily activity, he remembers about the drop. We can also use cell phone alarms as reminders to improve compliance. And sometimes the non-compliance is due to adverse effects or cost factors, so that also have to be addressed. Then there are some special situations like pregnancy and lactation. You have to remember in case of pregnant women, in the first trimester and second trimester, we can give brimonidine. But in the third trimester and during lactation, we have to stop brimonidine because it crosses blood-brain barrier. So we have to stop brimonidine. We can give it in the first trimester and the second trimester, but not in the final trimester or during lactation. And in the first trimester, never give prostaglandin analogs, first and second trimester. Avoid prostaglandin analogs. During pregnancy's final trimester or during lactation, you can give timolol or prostaglandin analogs, but not during the first and the second trimester. Best is you can do SLT to cover the period of pregnancy to avoid all topical drugs. If SLT is available, that is the best option. Then we will come to some new drugs which have come into the market recently, like Rho kinase inhibitors. They target trabecular meshwork, which is an entirely new mechanism of action. So we have two drugs. One is ripasudil, which has to be used twice daily. It causes a IOP reduction of 2.6 to 3.7 millimeters of mercury in primary open-angle glaucoma and ocular hypertension. When added with timolol, it causes an additional reduction of 1.6 millimeters of mercury. When added with latanoprost, it causes an additional 1.4 millimeters of reduction in IOP. The major adverse event is conjunctival hyperemia. So patients usually try to avoid it. We have to keep this in mind. The second Rho kinase drug which has been approved by FDA is netarsudil. So besides causing ROC1 and ROC2 inhibitors, which increases the conventional outflow, it also causes norepinephrine transport inhibition, which decreases aqueous humor production, and it also decreases episcleral venous pressure. It causes a reduction of 20 to 33% in IOP, and the advantage is of once daily dose. The only concern over here is in the studies done, it has been seen that it does not meet the non-inferiority criteria versus latanoprost overall. It meets the criteria in patients with IOP less than 26 millimeters of mercury. And Rocket 1 and 2 studies also show non-inferiority to timolol in patients with baseline IOP of less than 25 millimeters of mercury. The adverse events of concern are again conjunctival hyperemia, cornea verticillata, and perilimbal conjunctival hemorrhages. Then some new drugs are coming soon. One of them is latanoprost, latanoprostin B0. It is one molecule with two active metabolites with two complementary pathways. One is obviously latanoprost acid, which increases evioscleral outflow through MMP-mediated ECM remodeling. And the second active metabolite over here is nitric oxide, which increases the trabecular outflow. So Voyager study has shown that it is superior to latanoprost in mean diurnal IOP reduction. Constellation study has shown that it reduces nocturnal IOP, which timolol does not. Apollo and Lunar study show that it is non-inferior to timolol maleate. And Jupiter study confirmed the 52-week one-year safety of this drug. The dosage is once daily. And major adverse event is conjunctival hyperemia, eyelash growth, iris pigmentation. There is a combination available in neighboring countries. This is soon going to be launched in India also. Latanoprostin B0 and this combination netarsudil and latanoprost are going to be launched in India in a month or two. The magic effect of this drug combination, netarsudil and latanoprost, is that it covers all possible actions theoretically. It decreases aqueous production. It increases the both the conventional and the evioscleral outflow. It also decreases episcleral venous pressure. So theoretically, it covers all the possible mechanism of action, and the dosage is also convenient, once daily dose. And Mercury 1 and 2 trials have shown a reduction of IOP by 1.3 to 3 millimeters mercury more than the individual ingredients. The adverse event again of concern is conjunctival hyperemia in about 58% and cornea verticillata in about 15%. So as you see that we have a option of using so many drugs now, but the problem of compliance still remains. So how do we address the number one challenge, that is the patient non-compliance with the eye drop? Even in Western countries, even in European countries, it has been seen that there is a huge non-compliance. In fact, as high as 29 to 75% published in different studies. Now, the reason for non-compliance can be many, like comorbidities, forgetfulness, the number of eye drops, financial reasons, side effects, lack of knowledge. And this leads to fluctuation of IOP. So AGIA study, Advanced Glaucoma Intervention study, showed that if the fluctuation is more than 3 millimeter mercury, then there's a progression of visual field loss, significant progression of visual field loss. And IOP fluctuations are an independent risk factor. Asrani et al. Also have shown that large fluctuations of more than 5 millimeter mercury are significant risk factor in disease progression. So to address this, if we want a compliance independent treatment, which also improves the quality of life, we have sustained drug delivery systems. Two of them are FDA approved as of today. The first one is Bimatoprost SR or Duryasta, the commercial name. It is designed to release Bimatoprost over 90 days. And Artemis 1 and 2 trials have shown that it is non-inferior to topical timolol. And it has been shown that IOP is controlled in 80% of the study eyes after last injection at 12 months. So at 12 months also, the IOP is controlled in 80% of the eyes after the last injection. Again, the major concern is conjunctival hyperemia, and more than that, the concerning factor is endothelial cell loss, which has been shown to be 5% at 20 months. This is a small video which shows a very simple technique of implanting this Durasta or Bimatoprost sustained release implant in the eye, in the anterior chamber. As simple as that. The second FDA approved sustained drug delivery system is iDose travoplast implant. It is more like a eye stent with travoplast added in the eye stent. So it has been approved by FDA in December 2023, and it has been shown that it achieves travoplast levels above the efficacious dose across 2 years. And it is non-inferior to topical timolol over 12 months. So it is implanted just like eye stent in the angle of the anterior chamber in the pigmented trabecular meshwork. The adverse event of concern is conjunctival hyperemia and iritis. The advantage of this is it does not cause significant endothelial loss compared to Duryasta or Bimatoprost. Another major important factor of concern in these two drugs is the cost. The Durasta or Bimatoprost sustained release costs about $2,000, and this travoplast implant causes $14,000. So it is very, very costly. It is, I don't know how many people would be able to afford this implant systems. There are certain other implant systems, phase 3 trials going on. Bimatoprost ocular ring not very successful because of frequent dislodgement. Latanoprost punctal drug delivery system, again, not very successful or efficient because of epiphora and retention of these plugs. And TIC travoplast implant also not very successful because it was not non-inferior to latanoprost at all 9 points of time. But Spyglass is showing promising results in phase 3 trials. It has a bimatoprost drug-eluting pads at the optic haptic junction. And so we all know implanting IOL. So once it is commercially available, it will capture most of the mix market, I think, because in the other mix, you have to learn. There is a learning curve, and in this, there is no learning curve. And as the results in phase 3 trials are promising, once it is commercially available, I think it will be it has a very bright future. So to summarize, we have to remember the ultimate glaucoma reality, that it is a lifetime of treatment. It is, remember, it's not 1 month or 1 year or 5 years, it's a lifetime of treatment. And success relies entirely on simplifying regimes, reducing side effects, and ensuring affordability. So all these factors are important for the success of the medical management of glaucoma in any patient. Now, I would like to discuss a couple of cases with the residents. Is it okay?
Yes, sir. Absolutely fine, sir. I think Madhuri and Mithali and all the residents who are there on the panel can also come in and discuss.
Yeah, this is just for interaction with the residents. So the case one is a 69-year-old male with a IOP of 28 millimeters of mercury and CCT of 530 microns, open angles, VCDR of 0.6 to 0.7. And this is the visual field. So what should be the target IOP in this patient? Anyone, any resident can volunteer.
You don't need to be specific. You can give a range. Madhuri and
Yeah,
Mithali
it's a
and any
range.
other resident.
Target IOP is a range. You can.
So people are putting in the chat box, sir. Dr. Manish Soni says 13 to 15 and Hansa Yadav says mid-teens.
Yes. Mid-teens is right because this is moderate glaucoma, 0.6, 0.7 and about mean deviation of 10 decibels. So good. So which drug, if there are no contraindications, which should be your first drug of choice? Can you help me with the answers? I can't see the answers.
Dr. Manish Soni had put latanoprost, PG analogs by Dr. Hansa.
Yes, PG analogs because of the compliance factor, because of the easy dosage, once daily dose. So unless it is contraindicated, latanoprost eye drop is used. And then after follow-up, after 4 weeks, the IOP is 19 millimeters of mercury.
So there is one more option of beta blocker by Dr. Madhuri. Like, should we choose a beta blocker? What are the concerns? And
Yes.
when can we choose beta blocker?
Yeah, if the patient can't afford latanoprost, we can use the beta blockers, but we have to rule out whether the patient has any COPD or asthma or congestive heart failure. We have to rule out those things. We can start that because it is affordable and most of the patients, it is comfortable. So now my next question is, we have a IOP with latanoprost coming to 19 and the disc and visual fields are stable. So what should we do next? Any volunteers?
So Dr. Manish says add a beta blocker.
Yes, good. So the target IOP has to be in the mid-teens. Now 19 is high teens. So we don't want this high IOP. We want the IOP to be reduced further. So we add a beta blocker, timolol, and a combination, fixed drug combination is available, latanoprost plus timolol. So we can choose that for better compliance. Now, after 4 weeks, we have a IOP of 14 and 15 and disc and visual fields are stable. So what should be our next course of action?
So I think most of them, Dr. Hansa, Guruksha Kaushal, Dr. Madhuri Sharma, and Manish Soni, they say continue the same treatment.
Yeah, what I want to know is how frequent. Next follow-up should be after how many days? Because in this case, we have to tell the patient you have to come after so many weeks.
Any one of you can speak up. There's no point in typing, na? Because like I'm speaking for you.
Somebody can unmute and say how
Yeah.
frequently we should do a follow-up.
Manish, Ajaydeep, Mitali, Madhuri, Hansaya, you can unmute and speak up. There's no problem. If you don't want to come live, that's fine. But most of them write 3 months, sir. Manish, Soni, and Ajaydeep writes 3 months.
Yeah, we can do after 3 months, but usually the first case we do after 1 month and then after that maybe 3 months. Because just now the IOP has become stable, we have to repeat the IOP at 1 month and see that if it is maintained in 1 month, then we can go on for 3 month interval.
Any other things you want to see in, sir, 1 month follow-up, whether the patient is compliant, putting the drops properly,
Yes,
understood
as I said, the adverse effects and adherence regime and all those things have to be looked, and besides the disc and the visual field.
Yeah, especially the side effects if the patient is having, they will come up in a few weeks. So 4 weeks probably is a good time to at least have one visit initially after initiating the therapy. Very true, sir.
So then we move on to the next case. So these are the disc photographs of the right eye, and these are the photographs of the left eye. And the IOP is 33 and 32, CCT is 540 microns, open angle, and these are the visual fields. So and now in this patient, what should be the target IOP?
So everybody is in favor of early teens. Dr. Manish and Dr. Ajaydeep has typed early teens.
Yes, so the disc were advanced cupping and mean deviation is 17 decibels. So this is advanced glaucoma based on disc and visual field damage. So we have to have low teens or early teens. So that is the target IOP in our mind. Now, first drug, as we discussed before, we start with latanoprost, and after 4 weeks, the IOP is 21. So what do we do now?
So Dr. Manish says add a beta blocker, add timolol, add a beta blocker. That's the everybody's choice, it seems.
Yes, very simple. You add a beta blocker, fixed drug combination. Now the IOP falls to 16. Then what should we do?
So you have added atenolol and the patient is on latanoprost. The pressure is 14. We wanted
No,
early
the
teens.
pressure is 16.
Yeah, we wanted early teens. What next? So Manish Soni says SLT.
Yeah, if SLT is available, we can go for SLT, but the problem in most of the centers is availability of SLT. So what's the other alternative?
Add a third drug. That's
Yes.
Dr. Mitali says.
What should be your third drug of choice? Remember, we have to use a different class of medication.
So Dr. Manish is saying benzolamide.
Yes. So we can add topical carbonic anhydrase inhibitors. And after another 4 weeks, the IOP has come to 12 millimeters. So now what should we do? Any suggestions from the resident? Any volunteers?
Follow up at 1 to 3 months, RNFL, follow up after 1 month. So these are the various answers we are getting in the chat box.
Yes, we have to follow up again after 1 month, and if the everything is okay, there are no side effects, and the patient is adherent to the regime, and visual field and disc are stable, then we can call him again after 3 months. So I think the aim of this class was to give them the basic practical aspects of the medical management. I think they are answering very nicely. They have got the hang of things. What is the target intraocular pressure based on the glaucoma damage, and how do we stepwise increase the drug regime, first drug, second drug, and third drug. So this helps me to know that I am happy that they have got the hang of things.
Yes, sir. Very, very well, I think, presented and nicely covered all the aspects of the medical management. So I will request just 2 questions as the prize questions for this session from your presentation. We wish the fastest one to type in the chat box gets the prize.
Okay, just before that, these are my references, and I would like to thank Rajasthan Ophthalmological Society, especially Dr. Ankur Sinha and Dr. Nitesh for giving me this opportunity. Once more, I would like to thank you. And
Thank you,
as
sir,
far
for
as
coming. Thank you very much.
the questions are concerned, I would like to know what is the mechanism of action of netarsudil.
So you have to type in the chat box to back the prize. Whosoever will type fastest will get the answer. So Ajaydeep says rho kinase
Ajaydeep is
inhibitor.
first, rho kinase inhibitor.
Madhuri is the first one.
I think.
So any other specific you want? Hansa
Yeah, I
shows
want
increased
both the
tubercular pressure.
mechanisms of action. Rho kinase inhibitors is a general
Class of drug. Yeah.
I have given specific mechanism of action in my slide. I want both the mechanism of action.
Hansa says increased trabecular outflow.
That is one. That there are 2 mechanisms of action I had mentioned.
So Dr. Nitesh gets the prize for this?
No, is anyone answering the second mechanism?
No, I don't think so, sir.
I'll go back to the slide so that they remember this, because this is a very common question, rho kinase inhibitors. So unlike ripasudil, which is just one mechanism, ROC1 and ROC2 inhibitor, this one has another one. I'll show you. Yes. This also causes norepinephrine transport inhibition, which decreases aqueous humor production and also decreases episcleral venous pressure. So I think ideally the prize should go to the person who answers both.
So there's nobody who has answered both, sir. So I think we keep the prize for the next Kaksha.
Okay.
So we can have the second question, sir.
The second question is, which drug is contraindicated in final trimester and lactation period?
Now this I think everybody should know.
Yes.
So Hansa says brimonidine.
Hansa is first, brimonidine.
Hansa is brimonidine.
That is
so
right.
Hansa bags one prize. I would have actually said if Hansa wouldn't have got the second question right, that she gets the first prize also. So we get Hansa for both the things, but she'll get only one prize. Okay, Hansa?
Can I give one bonus question since one prize is remaining?
Yeah. Yes, sir. Sure, sir. So one prize goes to Hansa. Let us see who is the second winner.
Okay. Which drug is contraindicated in first trimester and second trimester?
Yes, sir. PG analog.
So Manish Soni gets the prize here.
Okay.
PG.
Yes, PG analog.
So we have got Hansa Yadav and Manish Soni as the 2 winners of this.
So congratulations to the residents. Now we invite residents to ask the questions directly from the Dr. Sanjay sir, if they are having any doubts.
Yeah, better to speak up rather than typing, because
So the basic of Kaksha series is that you can interact directly with the faculty. So unmute yourself, you can ask the question, and that would be better rather than typing the question.
Sir.
Yes,
Hello.
Manish. Yes,
Yes,
Dr.
Manish.
Manish.
Sir, what is the percentage that is reduced by every drug? Reduction in IOP by every drug?
Yes, as I said, prostaglandin analogs 30 to 35% and beta blockers 20 to 25%. There was a slide in which I had shown the percentages specifically. Yes, here you are. Alpha 2 agonists about 18 to 25%. Carbonic anhydrase inhibitors topical 20%. Trokinase 20%. But remember that once you have added the first drug, the second drug won't be having the same efficacy which is written over here. It will be slightly less. And sometimes the drug combinations, as I mentioned, have a better reduction of IOP than combined both.
Thank you, sir.
Any other question do we have?
Yes, anybody else? Sir, can I ask one question if you allow me?
Yes, yes, definitely.
Sir, actually the dose of timolol is twice a day, but
Yes,
with the fixed dose combination with PG analog, we give it once a day at
yes.
night or morning. So
Yeah.
should we give it in the morning also, or
See, there are two schools of thought because the timolol does not have effect on nocturnal IOP. So some people use it in the morning time, but
yes, sir.
one school of thought says no, we can use in the evening also. So there are proponents of both the theories. So you can try both, and whichever gives you the best result, you can go for it.
Okay.
There are equal number of people in both schools of thought.
Thank you, sir. Thank you. Thank you.
So with this, I think we come to the end of this session. And I think it was a great interaction with the students, especially in the case presentations, and a very nice presentation by Dr. Sanjay sir. He has covered almost all aspects of medical management, the how to use the drugs and how to combine the drugs and what to think about in terms of target IOP, a brief about the new advancement and the SLT, and everything has been covered in this session. So I hope the residents would kind of gain something from it, and it will be of their practical as well as clinical use. Even in their exams, a few questions may be asked. So thank you, Sanjay sir, for being here with us and obliging ROS for this masterclass. And thank you, Nitesh, for moderating this session. Thank you, Dr. Mitali and Dr. Madhuri, for being the residents on the hot seat. And thank you, everyone. Thank you, Numerotech, for organizing such a nice webinar. Thank you.
Thank you, sir.
Thank you, Sanjay sir. Thank you, Ankur Boss, to allow me to moderate this session, and thank you, residents, to come here. So this is the festival time. So happy Raksha Bandhan and good night.
Yeah.
Good night.
Happy Raksha Bandhan to everyone. Thank you. Yes. Thank you.
Thank you, sir. Thank you.
Thank you.